All right. Hello, everyone. Thank you for joining us. We're going to give it a couple more minutes for people to keep shuffling in, and then we'll get started. All right. So I think we're about ready to get started. Thank you for joining us, everyone. Today, we're going to talk about motion sickness and balance issues that astronauts face in spaceflight. And afterwards, we'll have a student presentation by Colton Thomas. So, Dr. Buckey, I'll let you take the floor.
Okay, great. Well, thank you very much. Let me go ahead and share screen. Okay, we seen that okay?
Looks great.
All right, so tonight we're going to talk about motion sickness and loss of balance. And,
Dr.
motion sickness, go ahead.
Sorry, we can see the presenter mode.
Oh, sorry, let me go back and undo that. That did it?
Yep, that did it.
Okay. Yeah, so motion sickness we may think is something that could just like ruin a pleasure cruise or a little fishing trip or something like that. But in an operational environment, it can have some fairly serious consequences. And also, it's just an interesting condition because it's really not clear where it comes from. Why does motion sickness develop, and what can you do to deal with it? And then talking about loss of balance, because the changes in the balance system are some of the most noticeable things about when you come back from being in space. Because while you're in space, your balance system is adapting to weightlessness, and you're not really aware of that until you come back, and then you're back on Earth with a balance system that's been adapted to weightlessness. So just starting out a little bit with motion sickness, if we go back in history, we can see that motion sickness has been an issue in other settings as well. So going back to 1944, in June of 1944, the AEF, or American Expeditionary Force, was crossing the English Channel in landing craft for the D-Day invasion. And this is a little quote from the book by Stephen Ambrose about D-Day. And what he's saying, Eisenhower, the commanding general, smelled victory in the air, but to the men of the AEF whose transports and landing craft had left harbor, the smell in the air was vomit, because of being in those landing craft with going over the waves in the English Channel was a pretty good motion sickness stimulus, and a lot of people ended up getting motion sickness. Well, motion sickness remedies have existed for a while, and one of the ones that's been around for ages and that is still probably one of the most effective motion sickness remedies around is scopolamine. So the scopolamine is a drug that's been used for years to treat motion sickness. Some of you may be familiar with it as the transdermal patch that you can put behind your ear. You can also take it by a pill, and I'll also show you another way you can take it later on. But at the time, they gave people the scopolamine in little packets that they could take in order to combat motion sickness. And as is often the case with people, is they figure if one is good, then two must be better. So some took twice the recommended dosage of the scopolamine, leading an observer in one area to note, by noon, all the Army personnel were in a drug stupor. Because one of the problems with scopolamine, even though it's very effective for motion sickness, if you take too much, it can cause drowsiness. So just raises another issue about motion sickness, that while being motion sick itself can be a problem in some operational environments, the drugs, you need to be careful with those too, because you don't want to give a drug that's going to incapacitate people. So you have to find that little middle ground in order to deal with motion sickness when it's there and it's a problem, but not deal with it so well that you put people out of action. Another great historical story about motion sickness, I don't know if you're familiar with Admiral Lord Nelson, hero of the British Navy, the hero of Trafalgar. His statue is in Trafalgar Square in London. What's less known about Lord Nelson is that he was a motion sickness sufferer. And they actually found some letters of his recently outlining what it was like for him to go to sea. And he said, "I am very ill every time it blows hard, and nothing but my enthusiastic love for my profession keeps me 1 hour at sea." So that sounds pretty horrible to be basically in the Navy and getting motion sick all the time. So what relevance does that have for spaceflight? Well, in space, during the adaptive portion of the mission, when you go from being in 1G into weightlessness, is a very high rate of motion sickness or motion sickness symptoms. So here this is a joking picture of people using their motion sickness bags, because that's often what happens in the early days of a flight. But motion sickness is more than just vomiting. So people will, can feel nauseated and not vomit. They can lose their appetite. They can also have this whole constellation of symptoms that you may have experienced yourself of, sort of feeling clammy, just feeling bad, feeling drowsy, having difficulty concentrating on things. So all those secondary symptoms of motion sickness are called the SOPITE syndrome. And so even though people may not be actually nauseated or vomiting, they may not feel great. And that can have an effect on performance. Why would you be concerned, though, about motion sickness? Well, this is sort of a picture to highlight the issue that you don't want to be vomiting if you're in a spacesuit. So if you are outside in an EVA and you were to vomit, all of that would be floating around weightless inside your helmet. And, if you aspirated that would be very bad for your lungs. So motion sickness is not a joke if you're going to be in an EVA suit and you're going to be weightless. So making sure that motion sickness is well controlled is very important. It's also one reason why spacewalks are often not scheduled early in a mission, to give people a chance to adapt to weightlessness and being in the weightless environment. So, how does motion sickness come about? Well, this is a little diagram of the inner ear. So on the top here, let me get the little pointer. Wait, this is going in the wrong direction here. Okay, so so here's the semicircular canals in your inner ear, the balance organ, and so those are really good for short accelerations. So they're good for controlling your body as it's moving. They don't really do well with chronic acceleration. And then within there's also the otolith, which has a sort of a horizontally and vertically oriented part to it, and it is good for sensing up and down. And the otolith has hair cells, which are covered by a sort of a gelatinous membrane that has stones in it. If you're upright in gravity, those stones bend the hair cells and give you information about your orientation, upright in this case. And then if you're weightless, you're not getting any information to your otolith. So one idea that has come up to explain why you might get motion sickness is this what's called the sensory conflict theory. The idea that when you're in a novel motion environment, you can put senses into conflict, and then through some mechanism, this causes you to get sick. So for example, if you're standing upright in 1G, your otolith tells you that you're upright. When you look out, your eyes tell you that you're upright. And you can also feel the pressure on your feet, and you can feel the sensation in the sensors within your, the bones and muscles, bones and tendons, all give you one consistent picture that you're upright. What happens in weightlessness is you're going to lose that input from the otolith. That now all of a sudden your eyes may be telling you you're upright in front of a panel, but your otolith is really giving you no information about up or down. And of course, you're getting an unusual sensation from the proprioception, the sense of in your bones and joints and muscles. So that conflict is then thought to lead to motion sickness. And this conflict doesn't always have to involve the vestibular system. I mean, in this example, we're saying that it does. But you can have an intact vestibular system and be using a VR headset, and that can cause motion sickness, again, perhaps by creating a conflict. And it's also, there are other overlying factors with motion sickness. You may have experienced a situation where, let's say you got sick in a car or in a boat or on an airplane, and then you go back into that environment later and you smell the smell that you remember. Maybe it was, you were a student pilot and you get that little oil smell from inside the cabin, and all of a sudden the motion sickness symptoms come back, even though you're not moving. So this psychological overlay that's there. And then there's also an effect of concentration. So I used to be a flight surgeon in the Air Force Reserve, and one of the planes we had was the F-4 Phantom, which was a two-seat fighter jet. And the back seat of the F-4 was like the cradle of motion sickness. It was very easy to get motion sick in the back seat of the F-4 as you were flying around. And I remember on one particular occasion, I was in the back seat and I was feeling kind of, feeling the motion sickness symptoms coming on. And the pilot says, "Hey, Doc, you want to fly?" I said, "Oh, sure." And so as soon as I got my hands on the controls and was controlling the plane, the motion sickness symptoms just evaporated. So there were these other factors at play. The ability to concentrate on what I was doing or to be in control of the motion helped to reduce the symptoms. There's a psychological overlay. And then there's also the sensory conflict theory, which is a great explanation, except for the fact it really doesn't tell you how this is happening at all. I mean, where in the brain is this happening? What is going on with motion sickness? It's really hard to tell. So there are a lot of different drugs used for motion sickness. I mentioned scopolamine, which was the one that was used for the D-Day invasion. And it was also used in the Apollo program and is still used today. One other common thing that's been used in the shuttle program and still today is promethazine given as an IM injection. And you would think that this would be very sedating, but in fact, it seems to work okay, but it involves giving an injection. And that's not something that's that easy to do if you're in an early part of, let's say, a SpaceX capsule flight and you're in a spacesuit. It's not that super easy to give somebody an injection through their spacesuit. And it's also not that easy to give if you're afterwards, when you recover and land in the ocean and you're flopping around in the ocean waves and you're feeling motion sick. That's not a great environment to be, dealing with, syringes and needles. So there have to be some other approaches that can be used. Could I just digress for a moment here? I forgot to mention that we talk about motion sickness in space. Don't forget that when you come back to Earth, you have a good likelihood of getting Earth sick too, because the same process is happening, but just in reverse. So one thing I just want to give a little plug for some of the work we've been doing in the lab. And so one of the things that we've been working on is using scopolamine through the nose. And in the past, we did a study where we gave scopolamine as a gel, and those are the little gray lines there. And you can see that, and then on the y-axis here is concentration, how much of the drug got in. And then on the x-axis, there is time. And you can see that this gel formulation in the gray bars, not a lot got in, and it didn't get in very fast. So if you're trying to replace an IM injection, this didn't look really that fabulous. And just recently, we tried instead using a nebulized aqueous solution of scopolamine through the nose and got some really fast uptake. So we're kind of excited about these early results and hope that perhaps we could look at different ways of giving scopolamine that could be used in settings like when you're in a spacesuit or if you've just come back and help to combat motion sickness. So that's a little bit about motion sickness. I mean, the other issue is just the balance system. And here's a little case study. A day or so after returning from Earth orbit, an astronaut drove his car into a long, tightly curved ramp at the intersection of two interstate highways, so one of those long curving exits. About halfway through the curve, he needed to pull over because he was having a strong sensation of tilt. He was feeling like he's tilting over. The slight sideways G-forces he had experienced in the turn had been interpreted by his space-adapted brain and nervous system as a significant body tilt. So again, he's back driving a car with a balance system that's adapted to weightlessness. The most likely explanation was that his balance system had adapted to weightlessness and had not yet readapted to Earth's gravity. And this was something that we looked into on the mission that I was a part of, the Neurolab mission. And on Neurolab, we had this rotating chair. And what this little diagram up here shows is that if you're rotating in this chair, you have a G-force going laterally. You have the force of, when you're riding on the ground, you have the force of gravity going down. And so the resulting force is sort of at 45 degrees. And it's true that when you spin in this chair on the ground, after it spins up and it's going, you feel, even though you're seated upright, you feel like you're tilted 45 degrees. And that's how you feel when you're spinning in that chair when you're in weightlessness. And so one interesting thing is, what should it feel like when you go into space? Well, when you go into space, will you have this downward force? No. You'll still have the lateral force, yes. So the resulting force is going to be like you're lying on your side. And on the bottom here, this is kind of a little diagram of what happened is that when we first got into space and spun in the chair, you still felt like you were only tilted 45 degrees. But as you went later on in the mission, you felt like you were tilting all the way over. But then the problem is when you come back to Earth, it takes a little time for your system to adapt, and you still feel this really strong tilt when you get these lateral G-forces. And your ability to perceive, your perceived tilt when you come back is way off. And so the example in that, the example I gave you, that the person there experienced a little bit of a G-force and they're feeling like they're tilted all the way over. And this happened, when I got back from being in space, my crewmate Jim, after we touched down, he turned to me and said, "Hey, tilt your head forward." So I did that. I tilted my head forward, and I felt like I was tumbling forward because all of a sudden my inner ear was really amped up. So I was back on Earth with a balance system that had been adapted to spaceflight. And you might think about what that would mean as far as piloting something. Here's another example. I think I showed this in the first meeting, so I'm sorry if this is a repeat for some of you. But this is Jacob Bloomberg from NASA, and he's going to give you a little video of what people look like when what their balance system look like after they come back from being in space. we go. I gotta get this pointer going here.
So, so what I want to do now is kind of give you a sense of what some of the changes do look like. So one of the tests that we have done in the past is called the tandem walk test. And this is a classical test of neurological function where a subject has to walk a straight line, eyes closed, arms over the chest. It's done in doctor's office, in neurologist's office all around the world. And we've been doing this test in a number of different experiments that we've been doing over the last few years. And so to give you a sense of what the postural instability that does occur, here we've got some video. So let me set this up for you. This is a post-flight test after a shuttle flight. So a shuttle flight about 14 to 16 days. And I'll show you the pre-flight. So this is the pre-flight version of a crew member. This is at Kennedy Space Center, tested just about 2 hours after landing. So this is the pre-flight version of it. And you can see our intrepid subject doing very well, as you might expect.
Are their eyes open?
They're closed when they do this, yep. And so here's the post-flight version of it. And now you can see increased instability, increased inability to, increased problems with maintaining a tandem walk. And you can see them moving off the straight line. So you can see quite an amount of instability post-flight. In fact, we have spotters on both sides to make sure that they maintain their stability. And so just to show you what it looks like on R+6, so that's 6 days after landing. And here you see a recovery here in terms of performance about 6 days after landing. And you can see it's not quite back to normal, but it's getting there in terms of recovery and, of performance.
So that's what that, so balance is definitely off when you're back. I'm just going to skip ahead a couple of things here. And so does this have any practical consequences? Well, what you're doing, if you're having people fly or operate the shuttle, for example, after a landing, they're going to be doing that with a balance system that's adapted to spaceflight. This is not unheard of. Those of you who are pilots know that you can get vestibular illusions just in normal flying, and so that you have to depend upon your visual cues in order to make sure that you fly safely, to trust your instruments and to trust vision. And that's very true in the space program as well, because this is a graph of shuttle landing performance. And you can see that there's a sink rate here. You've got some sink rates that are a lot higher than desired, even though you'd think that those would always be right on the mark. And some deviations from targeted touchdown velocity. Because you realize that people are coming back, they're piloting the shuttle with a balance system that's been adapted to weightlessness. They're trained to avoid these vestibular feelings, but still, if there's an air gust or some unexpected movement of the shuttle, it's going to be felt much more profoundly after you've come back from being in space than it would be in all your training beforehand. So there's a little, you got to be careful about having people operate or being in a situation where they have to depend on accurate information from their balance system after they've been in space. So just to wrap up, some motion sickness tips for people in space. It's just part of the normal adaptation to weightlessness. It's not a sign of weakness or anything like that, that just people are going to have this. It's a normal adaptation. One thing that can help is, it seems to be, is to minimize head movements. The fewer head movements you have, that tends to reduce perhaps the incidence of motion sickness. Another key thing is and this is what's done at NAS is don't try a medication for the very first time on the flight. So if one is going to use a motion sickness medication, always a good idea to try it out first when before on the ground before you go, to make sure that you don't have a reaction to it. And there is one caution that about 3 to 5% of people don't adapt to new motion environments. This was something that was, found in World War II. There were some people who got into the Navy and got on ship and spent a lot of their time motion sick and did not adapt to the new motion environment. And so that would be pretty unpleasant to be in space and not be able to adapt. So that can happen. So some neurovestibular tips in order to seat of the pants flying, not a good idea. So if you can't really rely on the input from your vestibular system after you come from being in space. One question that's often come up is, could you use artificial gravity to pre-adapt to new gravitational environment? Is there a way to have people be ready for the moon or Mars by giving them artificial gravity beforehand so they can walk out, not be motion sick, and have their vestibular system in place? It said use proprioceptive aids, which is a fancy way of saying use a cane. So people, if you get older and your balance system is off, or you can't really feel, the position of your feet and legs as well as you used to, that's a cane is useful for that, or a walker. And make sure that people can adapt to different gravitational environments. So it would be nice if someone's going to be on a long duration flight that they've been on a short duration flight first, to make sure that they have this adaptive capacity and can do okay. So that's all I got for right now. Just a little intro to motion sickness and balance issues in space.
Awesome. Thank you, Dr. Buckey. So at this time, we'll take some questions and then we'll follow it up with our student presentation. So Jerry, it looks like you're the first one up.
All right, thank you. So I actually used to be a boat captain and a sailing instructor before I went to education for 5 years as a teacher, and now I'm in med school. But
Wow,
this topic really interesting because I'm like mildly susceptible to seasickness, but there's such a wide range of experiences. And I've found that when I've used something like scopolamine in the past, there's some of I think it's called mydriasis. I don't know how to pronounce it, where you're getting the dilation.
Mydriasis, yes. Mm-hmm.
Mydriasis. And I found that it basically renders you pretty useless on a boat. Like if you have to do anything technical, you're just, sorry, I can't read, I can't write.
Yeah.
It's like, I can't read the GPS. So I was wondering if you see that as a complication with scopolamine injections, or sorry, the intranasal, and if there's a possibility also, because I think that stuff lasts a while, if you notice that maybe with lower doses you can achieve therapeutics and maybe have the duration of the experience taper off faster. Like, I don't know if you have a quicker peak concentration and a faster excretion. Therefore, let's say you wanted to get back to business and you didn't want to have the ocular side effects.
Yeah, so that is a great question because it's sort of the operational balance in treating motion sickness. And I think the approach that I prefer is that you don't necessarily have to pre-treat motion sickness or treat everybody who has motion sickness. There's gradations of motion sickness, right? So some people will be or they'll have those low-level motion sickness symptoms, or they'll feel sick and they'll vomit and then they're okay. And if you gave those people drugs, well, they may not need them, and then they're getting these eye effects and other things, so you've actually made the situation a little bit worse, right? Whereas there are some people, they get motion sickness and they're incapacitated, right? They can't do anything. In that case, they'd probably be better off if they took the scopolamine, even if they did have the vision problem, because before they weren't doing anything. So that's one of the reasons we want these sort of just time, work right now type medications, because this, you know, the idea behind the intranasal is that if you have somebody who really needs it, then they can get it, and they can get it acting right then. Otherwise, you can just wait and see what happens, because a lot of people will rise to the occasion with motion sickness. You know, the studies show that if people are challenged, they can still function, unless they got really bad motion sickness, then they can't.
All right, next up is Matt.
Hello, Dr. Buckey. Thank you so much. I just had a question regarding the usage of virtual reality applications and kind of determining how someone's effects of microgravity and the effects of motion sickness that they could have, or determining has there ever been a usage of virtual reality applications in kind of preparing someone for the motion sickness that they may experience, kind of having a disconnection between their visual and their physical effects, if they're feeling the gravitational effects coming from one way, whereas they're seeing a visual effect that's coming from a different way, kind of having that miscommunication within their two systems. Has there ever been the use of virtual reality to mimic that in order to prepare astronauts for spaceflight?
So I'm not aware of using virtual reality in that way, but that would be great for somebody to do a little research on that, because I may have missed it and it may have happened. But doing that, you know, trying to pre-adapt people to being in space, has been this search that's gone on for a long time. You know, the idea that can you adapt somebody to one motion environment and then have them go into another motion environment and not get sick. And the problem is the bulk of the evidence seems to show that the adaptation tends to be fairly condition specific. You know, so if you can get them adapted to, you know, whatever it is on the ground, but that doesn't necessarily mean they're going to be not get motion sickness in space. And I guess some practical evidence of that is that a lot of astronauts, right, had careers as fighter pilots or, test pilots and that sort of thing. They've obviously experienced a lot of weird motion environments, and they're obviously not getting motion sick all the time. They still go into space, and guess what? They get motion sick. So that is kind of the holy grail, to try to find a way to pre-adapt people to being in a unique motion environment. But so far it hasn't worked out well.
Thank you.
So it looks like, before I get to Jerry, it looks like we have a question in the chat. So Thomas Hoffman asks, do they still use scopolamine or Phenergan combined with dexedrine for initial space motion sickness countermeasures? Dexedrine added to treat the sleepiness side effects of scopolamine and Phenergan.
So what they typically use is, it looks like someone sent along they still, people just use Phenergan as an injection, not combined with anything. It used to be scopolamine combined with dexedrine was a very common medication that was used. But typically, at least in the shuttle program where I was, it was just Phenergan straight up. IM.
Thank you, Dr. Buckey. All right, Jerry has another question.
Yeah, I was just curious. I guess, like, from my experience, I've felt that if you can prevent the onset of motion sickness, it's a little bit more successful than, trying to treat it once it's started. But I don't know.
Definitely true. Yeah.
The case. And so I guess, what I've found on boats, and, people on boats have talked about this. So it's like, if you stay out of, areas in the boat where you don't have any visual cues, if you stay out of down below, you spend a little more time on deck, or if you do have to go down below, you can lay down so that, and my sense of it is that so that your vestibular system is not trying to constantly counterbalance these forces that your visual system doesn't know how to interpret. I mean, that's kind of how I've rationalized it, because I've felt that myself, if I go below deck in a storm or something, if I lay down and go to sleep, nothing's really an issue. But if I'm up, kind of stumbling around looking for things, and that's more of an issue. So I was wondering if I don't know if there's any sort of comparisons in a spaceship. Like, are there any areas that might be more or less inducive to motion sickness and others? And does a view outside of the spaceship have anything to do with anything at all?
Well, some people believe it helps. Yeah. But I don't know that I have any, solid scientific evidence for that. Some people say, well, on a ship, keep focusing on the horizon. In the airplane, it is true that if you give people some control, that they can do it. Same thing. We notice in cars, there'll be a car, people would be car sick except for the driver. The driver won't get sick, but everybody else does. So some of those things, if there's a way, and also all of a sudden, if there's an emergency, people, their heads clear in an instant. So it's all those other factors that come into play. That's hard to know exactly sometimes what the best approach is in a given individual.
Great. Then Maureen, you're next up.
Hi, Dr. Buckey. Thanks so much for your talk. I'm a M2 at Emory School of Medicine, and I think I'm interested in otolaryngology, ENT, and so I really appreciated this talk, and I was wondering if you could speak more about what role ENT physicians might play in human spaceflight.
Oh, well, there's been a lot of ENT research in space. You should go back and look at all sorts of rotating chairs and sleds that translate, and the posture platform that they sometimes use to test people with balance disorders was initially developed for the space program. So there have been a lot of ENTs have been involved in space research over time. I'm trying to think of Ashton Graybiel. Ashton Graybiel was sort of he's the titan of space vestibular research. He was at Brandeis for many years, did all like the sort of seminal work in the vestibular adaptation to weightlessness. And I don't remember if he was an ENT or not. So, but there have been a lot to that, a lot of ENTs involved in this kind of work.
Thank you.
All right, and it looks like we have another question in the chat from Sarah H. She asks if you have any thoughts on human spaceflight research involving deaf and hard of hearing participants who are used to relying on more visual cues.
So I haven't heard of any spaceflight experiments on that. I will say that one of the early observations in motion sickness is that there was a cruise where many of the people on the cruise were part of a deaf school. And this was back in the 1900s. But back then, a lot of the people who were deaf also had vestibular systems that didn't work. And let me get back to it and say that's not the end of the world if your vestibular system doesn't work. But anyway, so they had problems with the vestibular system, and on this cruise, everybody was getting motion sick. People were vomiting. They were at the rails. People were having a horrible time on this mission, except for the people who were the deaf people. They were just completely seemed to be immune. And that was one of the first observations that maybe it was the vestibular system that was important for the origin of motion sickness from that sort of observation with people who were deaf. But I don't know that that's ever been done in spaceflight. And just another thing too is I wanted to say that yes, your vestibular system very important. It's great. We love it. But it turns out there are people who have bilateral vestibular dysfunction, and they get through life just fine. A lot of times they don't even know it. They don't know they have it. And they play sports and they do all sorts of things. It's only when you examine them in more detail, you find out that they're really depending a lot on their vision. So your body has an amazing ability to shift the focus that it gives to different senses in order to deal with day-to-day activities.
Jerry, you're up again.
Yep, sorry, full of questions today.
We got all these
So-
great experiences. This is cool.
Yeah, I mean, I find the whole thing interesting. I hadn't heard of so it's promethazine, correct? Is that the
Yes.
same as the one mentioned in the chat? Phenergan?
Promethazine, yeah, right.
So is there a reason why that in particular has kind of risen to the top as the premier treatment, and why the intramuscular and the different, I'm curious about, why that's kind of risen to the top, and then also why has there been any research in intranasal delivery of that? And if not, why?
Yeah. Okay, so a couple of questions there. So promethazine, it was early work by Jim Bajan, who was a physician astronaut. Is that some people were getting really sick on shuttle flights, and by the time somebody gets sick, you really can't give them an oral medication. And promethazine was known to be an effective motion sickness medicine, which it's anticholinergic. It's also antihistamine, and it also has some it has some similarity with Thorazine. Who knows exactly what it's doing? It's got all these different effects, but anyway, they just found empirically that if you gave an injection of it to people who are motion sick and not doing well on a space flight, they got better. And often if you give it to it before sleep, they would sleep. So it just became the go-to quick remedy that people were looking for. So that it just kind of developed. And I don't know that it went through any formal selection process, but maybe it did, and I just don't know. And again, it's such a broad, I mean, the drug has so many different effects, it's not really clear what about it is making this difference, but it seems to be pretty good. Oh, and then the other question was about the nose. Yeah, so the thing is that in order to give something through the nose, it has to be very potent. So the one thing that scopolamine has going for it is that a dose of scopolamine is like 0.4, 0.6, maybe 1.2 milligrams, right? So not a lot. So, and that's why it works well in the patch, because you don't have to get a whole lot through the skin. And by the same token, you don't have to get a whole lot through the nose. But in order to try to get 50 milligrams of promethazine into your schnoz, that's a little bit of a challenge, right? So, so that's what makes scopolamine so desirable for these alternative modes of administration. It's a really very potent, small molecule, easy to get in those sort of situations.
If I could just follow up with one other question, which is the reverse. Has anybody used scopolamine as an injection?
Yeah. Yeah, so scopolamine's been used, it's used a lot clinically. Well, it used to be used a lot more. It used to be used as a sedative. And if you watch war movies, they'll say that it's used as truth serum. And then it was also used a lot to reduce secretions. So Joe Baio of anesthesiology fame, they used to give people scopolamine in order to reduce, salivary output, which it does very effectively. I mean, that's one of the most pronounced side effects. If you gave somebody scopolamine and they're not getting a dry mouth, it probably didn't get in, right?
All right, thank you, Dr. Buckey. So it looks like we don't have any more
Sure.
questions. So I'm going to pass it over to Colton Thompson. And Colton, if you could just introduce yourself, tell us where you're from and what you're going to be talking about.
Sure. So I'm Colton Thompson. I'm currently an M1 over at the University of Michigan Medical School. So I know nothing. I'm like 3 months in, so I promise if I mispronounce things, I'm trying. But kind of got interested in this stuff. We had a talk from Jim Bajan like a month ago, who was
he was on the article about the first use of promethazine in space. So
Yes, he
ask him
was.
about that. All right.
Oh, yeah.
All right.
He talked about it. Don't worry. He let us know.
All right.
He's like, I cured the stuff. So that was pretty cool. So this seemed like a fitting topic for me. So I will do my best to try to share a screen here. And how are we looking?
Looks great.
Good.
All right. All right, so we'll go here. So motion sickness, what is it? A lot of this stuff we already just covered with Dr. Buckey, but 80%, up to 80%, 60s to 80% of astronauts, typically during that early phase, like Dr. Buckey mentioned, as they're climbing, or the first couple days or so of space. Most common having this motion sickness. One thing that Jerry was saying, he's a mariner, and pilots all the same, might have experienced stuff like this before in the past. And one thing that they found was those who, were foreign pilots or more science type did not matter all that much to their prior exposures to ground motion sickness, affected them in space, similar rates. The symptoms, very common to the ground motion sickness, like we kind of mentioned earlier, the biggest problems being the vomiting and the anorexia. And the vomit bags they developed had really good ones that kind of collected everything, because if you vomit in space and it just projectile, it gets caught in things and hides like any other liquid. It's hard to kind of catch. And obviously could cause important mission critical tasks to not be performed on time or properly. So the cause, a lot of things that we just discussed. Two of the biggest considerations that they had primarily were fluid shift that we've discussed in other lectures, from the legs, up to the thorax, more spread out than it typically is due to the lack of gravity or sensory conflict. And one thing that really indicated to them that the vestibular system, sensory conflict, was a little bit more likely was the Mercury and Gemini missions, which had much smaller volume for the astronauts to move around in. And they reported very low symptoms of any kind of motion sickness. So that was one of the big ones that really pointed towards the vestibular system early on. And a big thing that they've kind of learned was that motion sickness on the ground and in space is very heritable, and there's a large degree of heritability. So some astronauts may go up and have no symptoms at all, with or without any prior experience or like habituation that they'll kind of try on the ground, which we'll get into in a little bit. Just will not have symptoms. Some have very severe symptoms, and that a lot of that happens to be heritable. So Jim Badgen, who we've spoken about on the right, and then a lot of the drugs that we already talked about. So scopolamine, scope dex was something that they tried prophylactically. And there was a retrospective study done by Dr. Jim Badgen with the scope dex prophylactically versus promethazine used after symptom onset. And scope dex had an efficacy of about 50%, whereas the promethazine had an efficacy of around 90%. And that indicated them that that was definitely the number one treatment option. And that was IM 25 to 50 milligrams, which is the same dosage on Earth. So one of the big problems with promethazine is the sedation risk. And they found that in space, opposed to on Earth, where the sedation is anywhere from like 30 to 50% sedative symptoms, it was only about 5% in space, with those symptoms also residing pretty quickly within a couple hours or so. And they disregarded promethazine IM infusion before bed. So those people that did take it like near sleep time, they did not include in the study. So there is definitely sometimes a slight effect, but even during the day, symptom onset, only 5% or so in space. And so that's a weird, that in my kind of reading, that was one of the weirdest things that we kind of went over, why in space, some side effects, on Earth, none. And that brings up the fact that, in space, there could be a lot of pharmacokinetic changes, as well as physiologic and obviously external stressor changes. So one thing that they talked about was, or Dr. Buckey mentioned was, whenever you have a sudden urge or a sudden sympathetic jolt, a lot of those symptoms subside. So that's one external stressor might be the difference. But there's also changes in drug pharmacokinetics and dynamics, as well as just physiology happening. And then another thing that we talked about, habituation, the autogenic feedback training, the chair. And in our talk, Jim Badgen mentioned this, and Dr. Buckey might be able to talk on it. People did not like the chair very much, and some often thought that the treatment was worse than the real thing itself. People got quite sick in the chair, and their symptoms may or may not occur when they do take flight. So that did not seem to bode well in space or among the astronauts. They did not like the chair. So that is not exactly a great option, although in a comparison to promethazine, it was more effective. And what's next? One thing that Matt, I think, asked was VR. That is something that they are looking at. VR training. They do some VR training as well. And like Hawaii, they've done like real long-term training missions that they do in some remote areas of Hawaii. They give goggles to astronauts that are, in selection and stuff. They do some training with the VR and some habituation, as well as with like the vestibular system. Motion sickness seems to be a point of some, like a drug treatment that is going to be consistent in space travel, whether that be on the ISS or going to the moon. And as we mentioned, coming back to Earth, you also have it. So theoretically, going from space to Mars, those symptoms might also occur. So motion sickness is not going away. And this is an opportunity to study, pharmacokinetic and pharmacodynamic changes that might occur. And obviously the genetic variants we already sort of touched on. So that's all I got for you guys. I will stop sharing my screen, and thank you.
Awesome. Thank you, student Dr. Thompson. Appreciate it. And as always, thank you, Dr. Buckey, for your wonderful lecture. And we'll take a few minutes for last minute questions. All right, so it doesn't look like there are any. So thank you all for joining us. Feel free to join us next week. We'll be discussing the cardiovascular effects of microgravity as well as extravehicular activity. And that'll be followed up with a presentation by Mimi Lon. Thank you everyone for joining us.
Thanks, everybody.
Thank you.
Thank you.